So hi, my name is Dr. Danielle Hammond. So I'm a Canadian-trained hematologist oncologist and now the Chief Leukemia Fellow at the MD Anderson Cancer Center in Houston, Texas. So I'll be answering the question about what is MRD and when do we need to test and why does it matter? So MRD stands for minimal or measurable residual disease, and I'll be speaking to how it relates to the treatment of acute leukemias for the most part. So traditionally, we've defined remission for blood cancers, especially leukemias, as when we look at the bone marrow biopsy sample, when we look in the bone marrow, the pathologist will see less than 5% of all the cells in your bone marrow being the leukemia cells or blasts, in addition to recovering with near normal blood counts. And that's been the definition of remission or complete remission that we've used for decades for acute leukemias. So over the past decade, there have been some laboratory techniques developed that have allowed us to measure at a deeper level if there's any microscopic bits of leukemia that we can't see just looking underneath the microscope. And that's really what MRD is referring to. So there's two major techniques that are applied to bone marrow biopsy samples to detect MRD. And very importantly, the techniques are complementary. So it's preferable that you actually apply both techniques in parallel because again, they give complementary but slightly different types of information. So the first technique that we use to measure at a deeper level, is there any microscopic bits of leukemia left, is something called flow cytometry, or sometimes multi-parameter flow cytometry, which is really just a fancy way of saying that we've taken the bone marrow sample and we've run it through a machine that actually uses laser technology to pick up on unique fingerprints of the leukemia cells. And using that technique, we can detect as little as 1 in 10,000 leukemia versus healthy cells in that bone marrow biopsy. That's the first technique used, and probably the easiest technique to apply. The other technique that we use to detect microscopic bits of disease in the bone marrow is really genetic sequencing. And so the vast majority of acute leukemias do have genetic changes or changes to the DNA within those blood cells that defines the leukemia. And so if we know those genetic changes are present at initial diagnosis, we can go back at later time points to see if those genetic changes are still there. And it really depends exactly what genetic sequencing technique is used, but we can easily detect if there's 1 to 2% cells left with the genetic change. And for a slightly different technique, for certain cases, we can even detect as little as 1 in 100,000 abnormal cells. So that's the technology behind it. And in terms of when do we measure it and why does it matter, is that for people that are in that traditional definition of a complete remission, we know that if we measure at these deeper levels with these specialized laboratory techniques, it's really one of the strongest predictors of relapse. And so the first time it's important to measure it is when we're assessing response to therapy. So certainly after the first cycle of therapy for most acute leukemias, and then really near the end of your planned treatment for your acute leukemia, we should be checking again, ideally with both of these techniques in parallel. And if that bone marrow sample is positive by either or both of those techniques for microscopic or surrogate measures of the leukemia, then that's a strong predictor of relapse. It's not certain, but it's a strong predictor. And so when we see that then prompts your physician to consider additional treatment strategies, try to get rid of that residual disease. And the two major strategies that have been developed is one, if your leukemia has certain genetic changes, we actually now have very targeted therapies that specifically will go after leukemias with certain genetic changes. And so those are often called molecular inhibitors. So for patients that have leukemias with mutations in genes with funny names like FLT3 or IDH, we actually have specific drugs if we're still detecting leukemia cells with those mutations there. Another approach to getting rid of this microscopic bits of disease is immunotherapy. And this has been very successful for one flavor of acute leukemia called B-cell ALL, or acute lymphoblastic leukemia. And there's now a variety of techniques. There's a drug called blinatumomab, or Blincyto, that can be used for this purpose. And in some cases, a newer technology called CAR T cells can be used to get rid of residual bits of that B-cell ALL. And so this is very important for when patients are finished therapy with traditional chemotherapy agents, but now there's consideration to proceed with a stem cell transplant as a potentially curative strategy for an acute leukemia. And that's really critical to measure what we call MRD at that point, because we know patients that have MRD positivity or residual bits of leukemia detectable by these techniques, we know that they would have a much better outcome if we got rid of that measurable residual bits of disease prior to going on to the stem cell transplant. That's a really important time point to check. The other sort of major utility of monitoring for this is that for patients that are in a deep remission, so initially are MRD negative by either of those techniques, at least for the first few years after achieving that deep remission, really your medical team should be checking intermittently to see if there's any sign of early relapse by, again, measuring using these very sensitive techniques. Because ideally then, if we detect the leukemia coming back only at that MRD level, that gives us a better chance of getting it back under control or back into a deep remission if we're detecting it earlier, rather than waiting for the bone marrow or your blood counts to look abnormal. But I do want to mention 3 caveats to MRD testing. The first one is that the results are only as good as the lab technique can measure, and only as good as the sample that's given to the lab. So sometimes bone marrow biopsy samples are insufficient really for the lab to do accurate testing. And also there's just limits to the technology. So it's really important to emphasize that even if somebody's bone marrow is MRD negative at a certain time point, it doesn't mean it's a guarantee that there won't be relapse, but certainly there's a lower risk of relapse if that's the case. The other thing to point out is that consistent with sort of normal aging, we sometimes can see genetic changes that also appear in leukemias. And those genetic changes are called clonal hematopoiesis, or sometimes the short term is CHIP that you might hear about. And so it's really important not to confuse those rather normal genetic changes in blood cells with the residual presence of a leukemia. And it can be a little bit tricky to sort out, but the lab has ways of sorting that out. And last but not least, actually, in terms of caveats, is again, you really only want to be measuring for minimal residual disease if your team is going to act upon that. So either in terms of closer monitoring or changing treatment strategies. So you don't want to really be measuring something that is not going to change the plan, because these are still expensive technologies and time consuming. You always want to make sure that resources are used wisely. So that's how we think about MRD, or minimal residual disease testing, in our world.